Yeah, thank you very much again for the invitation to the bus. It's my pleasure to be with you. And I was asked to talk about the ERC 2025 Special Circumstances Guidelines. As you know, they have been published at the end of October in 25 and presented in Rotterdam at the ESC 25 Congress. I do not have a conflict of interest besides being part in many societies which take care and do research in special circumstances of cardiac arrest. So this is the title page of this publication from last October. This is a summary and an overview of the different special circumstances which we are going to talk through. I've listed some with arrows, and we'll just go through some of the most important findings and interesting topics along the way. So a lot of special circumstance patient, new ones have been included, for instance the obese ones, the patients also with pectus excavatum as you see here, and pregnant patients have also been included. One thing which I would like to highlight, and this is shown here also in red with a red arrow, is the inclusion of extracorporeal CPR, so with ECMO. And another thing which has become a major topic, but not as strong as CPR, is the use of ultrasound in ALS in general, but also especially in circumstances. We'll look at this in more detail a little bit afterwards. As you see here, there are some rings basically of cardiac arrest treatment, which of course is always often to do with recognition, then of course following the ABCs, following the ALS algorithm, detecting reversible causes, treating reversible causes, minimizing the no flow time, reducing the low flow time duration, and coming back of course to return of spontaneous circulation. Also, as I said, with the use of eCPR, mostly in hospital, but also now more and more in extra hospital setting. And again, we'll see this a little bit later also. In the cath lab, there's also the eCPR algorithm now included, as you see here in the bottom. Also in the post-cardiac surgery algorithm, which is also new, like the cath lab with the eCPR on the bottom of this algorithm. And I just wanted to show you also the drowning algorithm, because as we know, most of the facts here are of course evidence-based, but some things like the 5 ventilations here in this algorithm of the drowning patient, but also in the asphyctic patient, for instance in the avalanches, which is a rare situation of course, the 5 ventilations are not well defined or researched for in any prospective randomized controlled trial. And there was a big discussion whether to leave them or to put them away, but fortunately we were able to keep them because of course pathophysiologically wise, it's of course reasonable in an asphyctic patient to give him some ventilations first to fill up his oxygen store in the lung before you start chest compression. Okay, let's go into the first cardiac arrest, which is the traumatic cardiac arrest I would like to talk about. You see the algorithm on the right side. Of course, I cannot cover everything in detail, but I would like to give you some overlook and overview. And then, of course, please look into the guidelines, look into this presentation again, and see what you find of interest, which can be used for your patients. So traumatic cardiac arrest has a high mortality, of course, as we know. Patients can have a good neurological outcome. There are some preventable death reasons which can be treated. And of course, there are some other reasons when CPR should be terminated. The question, of course, is should chest compressions be done if the patient is hypovolemic and there's no blood to be pumped around or insufficient blood to be pumped around, or other reasons that pump cannot be pumped around because of obstructive obstructive shock state, like with cardiac tamponade or tension pneumothorax. Okay, so what should we do then? What is the role of inotropes? What is the role of vasopressors in such a situation? So we should treat the reversible causes like hypovolemia. There has been a role of RIBOA in the past, a resuscitative endovascular balloon occlusion of the aorta, but this has been de-emphasized in the nowadays guidelines. Now we say hypovolemia should be treated, hypoxia should be treated, tension pneumothorax and cardiac tamponade, if you are able to do that. And this is basically given also in these guidelines. So basically, if there's cardiac arrest, not traumatic, then go for ALS. But if you have a traumatic cardiac arrest, look for the 4 H's, look for the 4 T's, and treat the 4 H's if they are present. 4 T's are very rare in traumatic cardiac arrest. Treat reversible causes. Do the resuscitative thoracotomy if you're able to do that. And if you have ROSC, pre or intra-hospitally, treat the patient further. If you do not have ROSC, then of course consider to terminate CPR. Cardiac arrest in the operating theatre is something which we may happen. I have given another lecture during this congress where I say that the risk of cardiac arrest intraoperatively is 100 times lower than in the first 30 days postoperatively. So you may look up on this presentation also. So what about cardiac arrest in the operating theatre? Well, it has been assessed for cardiac and non-cardiac surgery patients. Still patients die because of hypovolemia, because of anaphylaxis, because of major cardiovascular other events like myocardial infarction. So this has been a major issue. But this talk is not about what happens, but how can we treat it and what should we do about it. So basically, if there's a patient, and I go through this a bit faster, then of course, where you see that he is deteriorating, then you should look at systolic blood pressure below 50 and a falling ETCO2. Then, despite proper intervention, CPR should be started. But of course, as we have heard before, if this patient is also hypovolemic, then probably performing chest compressions in hypovolemia is not very helpful, but you have to treat the underlying causes like the 4 H's. Inform, of course, the team, adjust the height of your table, go for sustained ETCO2 of higher than 20. Try also to find reversible causes. Do an ultrasound, consider eCPR, talk to your surgeons if there's anything they can do, also with helping setting up the ECMO if that's an option. And of course use that equipment which you're able to use. Local anesthetic systemic toxicity, this is something which anesthetists are very familiar with. We developed for this guideline for the first time an algorithm which is basically very linear, and this is about stopping local anesthetic application, performing, giving pure oxygen, starting CPR if the patient is in cardiac arrest, but also giving the lipid rescue therapy as you see here, repeating the dosage, giving a continuous dosage if there is still a necessity, performing ALS, standard ALS as you know, and if everything fails and the patient does not, let's say, regain return of spontaneous circulation, eCPR should also be assessed. So this is very important. Cardiac arrest in pregnancy is also new and a big topic. So the first question should be, is this woman pregnant at all? So if you have the idea that the patient could be pregnant, treat her as pregnant, and every woman in a excuse me, every patient in an age where pregnancy is possible should be considered as being pregnant. So maternal rest team should be called. The patient should be left put in a uterine left displacement position. As you see here, there are different options to do that, to decompress the vena cava inferior, and then there are modifications to the advanced life support in obstetric patients. So one thing which I wanted to highlight, this is this here. These are the 4 H's, the 4 T's, as you know them, but there are also the 4 P's for pregnant women. I will come to that afterward. So the airway is special and is more edematous. It's more narrow, as you know, in pregnant women. This is the 4 P's, which we will discuss briefly. So you know the 4 H's, you know the 4 P's, the 4 T's, but you may not know the 4 P's in pregnancy. This is preeclampsia and eclampsia, puerperal sepsis, and placental and uterine complications, and the peripartum cardiomyopathy. So this should be also considered in pregnant women. Then, of course, there are different options which should be considered, like medications in a patient in cardiac arrest. But most of all, if the patient has a baby with more than 20 weeks of gestation, and if ALS fails to restore spontaneous circulation, you should consider early performance of hysterotomy, of course, by a team who is experienced in that. And of course, if the mother regains consciousness and if the baby survives, post-gestation care, as you know, is very important. So we mentioned this, that hysterotomy is time sensitive, so consider this early, so best in the first 10 to 15 minutes of your ALS procedure. And you have to be skilled. So this, of course, is something which has to be trained regularly. So we're coming to a bit more rarer forms of special circumstances like hypothermia and avalanche rescue. I will guide you briefly through that. So with accidental hypothermia, either you measured core temperature or you know from medical history that this could be hypothermia. And then, of course, you should consider, has the patient vital signs, yes or no? And then you end up on the left or on the right side. You end up on the left side or here on the right side of the algorithm. And then here on the left side, there is hypothermia 1 or hypothermia 2 and 3, while here on this side, there's hypothermia 4, which is basically here on the bottom. So coming further down on the left side here, you consider the impaired consciousness, yes or no, and then you end up either in hypothermia 1, where you go to the first hospital where the patient is only mildly hypothermic, where you rewarm him externally and also allow for passive rewarming with his own metabolism, or you can also rewarm him from outside, or you go on the middle part of the algorithm, which is this column here, where you basically have an impaired consciousness, where you have signs of possible cardiac arrest because of hypothermia, which is mentioned here. And I just wanted to mention a new indicator, which is a heart rate below 45, which is also considered as a risk of, or as a sign of risk of cardiac arrest because of hypothermia. And if only one of these signs is present, you should go to an ECMO center. And if no of these signs is present, then this patient is not at risk of cardiac arrest because of hypothermia, and you should go to the nearest hospital and rewarm him actively externally, for instance with forced warm air and electrical blankets, warm blankets, or forced warm air and warm infusions. And then you can end up in the right algorithm here, which is basically if the patient has no vital signs, then you go down, you do CPR, but you may stop if there are signs which are not compatible with life. Then you start CPR, or you have a patient who had some signs or some symptoms or signs of potential cardiac arrest because of hypothermia, then he may have had a witnessed hypothermic cardiac arrest. You start the CPR, you end up here, and you perform CPR and check for the HOPE score, which is basically a 6-factorial risk stratification score to assess the likelihood of good neurological, let's say, of survival after hypothermic cardiac arrest and rewarmer with extracorporeal life support. And if the score is higher than 10 or higher, then you should go for rewarming on ECMO. Otherwise, you should consider to terminate this, the CPR, because this patient with a HOPE score less than 10 has very poor chances of survival. If the patient survives, of course, you do the post-resuscitation care algorithm. This is also to show you that patients who are hypothermic, they may be they should be measured for core temperature, as you see here, and then they can be defined for hypothermia 1 to 4. You can do that also with clinical findings, but this is less precise. But if you do not have any temperature measurement, you can assess your patient who is hypothermic but still has some vital signs. And if you do have to do that, then you should rely on the consciousness level. And depending on the consciousness level, as you see here with the clinical findings and this red arrow, you have a patient who has decreasing consciousness up to unconsciousness and no detectable signs. And this gives you, just this decrease in conscious level gives you a risk stratification for the risk of developing cardiac arrest because of hypothermia. So if you have a patient basically who is unconscious and has no vital signs, it's very likely that he's in hypothermic cardiac arrest or is very close to that. And this is called the revised Swiss staging. So if you have a patient, this is now the avalanche algorithm. With an avalanche burial, you should decide the duration of burial. And so after assessing the airway, you see if he's buried less than 60 minutes. When this is the case, it's presumably, if he's in cardiac arrest, it's presumably because of asphyxia, and certainly not because of, very likely not because of hypothermia, because he has not been long enough in the snow to become hypothermic below 30 degrees, where the likelihood of developing cardiac arrest because of hypothermia is high. And if the person is buried longer than 60 minutes, then there is possible hypothermia as a cause of cardiac arrest, and then you should consider this patient in the hypothermic algorithm and proceed accordingly. Of course, CPR is done in both occasions, but here in normothermia and with the 5 rescue breaths, because this is asphyctic and you have to take the 5 rescue breaths as in drowning patients. And then, of course, coming down here, you measure the core temperature, and you end up on the next slide for the CPR stratification on how to proceed. So if there are lethal injuries, of course you stop. If the duration is less than 60 minutes, you have a warm patient, you should measure the core temperature, and if the patient is warm and less than 60 minutes, you're in a normothermic warm patient, you perform CPR for 20 minutes, and if there's no rescue, you consider termination of CPR. If the duration burial is longer than 60 minutes or you don't know it, you check the ECG. Again, if you have a VF, ventricular fibrillation, or PEA, and you measure the temperature, again, normothermia or hypothermia algorithm, of course, with HOPE score, and then with a HOPE score up above 10, you go for the ECLS. Going back to the ECG, with ECG in asystole, you check if it is witnessed cardiac arrest, which is better chance of survival, again measuring temperature, again proceeding to normothermia or hypothermia. And if it's not witnessed cardiac arrest and the airway, as you checked before, is obstructed, then you terminate CPR. Otherwise, you have a patient longer than 60 minutes buried, asystolic, which is not good. Witnessed cardiac characteristics is also no good, but still some chances of survival. And the airway is patent or unknown, then you end up again here, and you decide based on the esophageal temperature again if you are normothermic or hypothermic, and proceed from there. So there's also an algorithm for intermittent CPR. If you have no mechanical chest compression available and the patient is cold with a temperature above 28 degrees, then you would not do intermittent CPR. But if the patient is cold, you may alternate between 5 minutes of CPR and no CPR. And if it's very cold, which is on the right side here, you may even do 5 minutes of CPR and up to 10 minutes of no CPR for patients who have to be transported with upsiling, transported on carriages. For hypothermia, I just want to say that if the patient is in CPR or in cardiac arrest, you do CPR, then the temperature of 45 degrees, which is life-threatening, you have to bring it down as soon as possible, down to 39 degrees. And this is very important, bring it down as soon as possible. And the second thing to remind is the 130 milliequal of sodium, which are very important. If the patient is very hot, like the 45 degrees, you should check for sodium and replenish this as soon as possible, as you see here, and provide fluids. And if he has other symptoms, then go into the special circumstances for those symptoms, like for hypoglycemia, treat him accordingly and provide ALS measures. There's also a new table on toxins inducing hypothermia. I cannot go into this right now, but you see a lot of substances, you see a lot of mechanisms, symptoms, diagnosis, and specific treatments. And there's also a new algorithm on malignant hypothermia, which is something which can happen in the OR. This, similarly to the local anesthetic toxicity, is a new algorithm. It's a straight-through linear algorithm from diagnosing malignant hypothermia to eliminating the agent, to administering dantrolene, and to treat symptomatic treatment and to manage malignant hypothermia. So there is also, and this is now already the last part, a section for cardiac-related special circumstances in the cath lab, which is basically about prevention and being prepared to detection and reacting and to resuscitating. Again, for all these cardiac reasons, cardiac arrests, eCPR is very important. Prevention is better as cure, as Hippocrates said already. And of course, we have to detect that a cardiac arrest may be imminent or is happening. Then we have to call early help, and then decide again if this is this algorithm of cardiac arrest with arrhythmia, which is defibrillable, which is the left side, or is it a non-defibrillable algorithm, and proceed accordingly. And the same is true also for cardiac arrest patients after cardiac surgery, again with a prevention and preparedness part, where we have to be trained, where we have to be skilled, where we have to have the algorithms. And then, of course, we have to detect these patients, to provide them early treatment, early alarm, doing an echo, also to detect any reversible causes. Think about the 4 H's and the 4 T's. And then again, depending if it is defibrillable or not defibrillable, proceed accordingly with arrhythmia therapy. Again, considering eCPR, and also very importantly early wristonotomy within 5 minutes of cardiac arrest to give this patient the best chances possible if he has for instance a pericardiac tamponade or a bleeding. There's also a section for patients with left ventricular assist devices. This is a complex and very specific algorithm, which I will not discuss right here. But again, early detection, early diagnosis, early treatment, very specific treatment for these LVAD patients is also very important. And they have very good chances also of survival. That's what I would like to give you here. And of course, you can also scan the guidelines, load them down on your app. And I hope that I was able to tell you a few new things, maybe also to alert you on possible new issues. And please check these guidelines more specifically and more extensively after these lectures. And I hope you liked my presentation. If you have any questions, please feel free to ask. Thank you very much for your attention.